okay? Now, you can do pharmacoepidemiology in older people, in adults, and men, and women, and children. But for pregnant women, we have no data here, and we only have post-marketing data, okay? So this is why randomized control trials are usually not used. We call them observational studies, and these observational studies need to be repeated. Why? Because each and every one of them have potential important biases. So you don't want to make a mistake. So it's good in post-marketing studies in pregnant women, it's good to actually repeat the studies. So I have a research question, I do it in Canada, you know, we redo it here in Brazil, we do it in the US. It's important to do repetition of findings. It's very, very important. So again, just to make a point, this is really the population that is studied for an indication or multiple indications before the drug is on the market. But once a drug is on the market, this is really the population receiving the medication. And this is why we often see differences in findings from pre-marketing research and post-marketing research. It's because it's not the same people who are actually taking the medication. And pregnant women certainly fit this box. So this, I'm gonna go fast. You know, we always think of randomized controlled trial as the gold standard, which is probably the case to look at efficacy, but really it's, you know, once the medication is on the market, you see something very different. And not only in pregnant women, you think of statins. You know, statins are often used to treat hypercholesterolemia. In randomized controlled trials, it was blockbuster. It was so good. But once the medication was put on the market, it wasn't as good. Why? Because people don't have symptoms. And you know, in order to have a good effect, it has to be used consistently for long periods of times, and people were not observant or persistent with their treatment, okay? So there's always a reason why these two are different. But in pregnant women, the gold standards are probably around here because we don't have randomized controlled trial. Oh, I just want to say, it is important because we had this discussion this morning. It is important because we are in this situation for pregnant women. It's important to have mechanistic studies. It's important to have animal studies. Why? Because many times we can't explain the association that we actually find. If you think of thalidomide, and I don't know, do I have a, I don't think I do. Sometimes I have a slide on thalidomide. Thalidomide is the poster child of teratogen. I mean, terrible, used for nausea and vomiting of pregnancy. I mean, terrible teratogen. So it's our poster child. Well, did you know that once before the medication was actually put on the market, the animal studies that were performed didn't show teratogenicity? It's amazing. First of all, we agree they were not well made, those studies, and this thalidomide actually changed the way we study medications in pregnancy now. But it's amazing that, you know, we always think of animal studies preceding observational studies. It's not always the case. I think they have to feed each other. You know, observational research can feed animal research and so forth, because we need to understand what's going on. So this is just for you to know that 60% more, even 60% of pregnant women actually take medications in pregnancy. It goes all the way to about 70% in breastfeeding women. But 90% of the medications that are available on the market are not to be used in pregnancy. So if you read the label, it says should not be used if you're pregnant, or if you're pregnant, you should really have a good discussion with your healthcare provider. So, you know, if they're not contraindicated, you know, absolutely. So there is a need for research. to help these women. So again, although thalidomide is off the market, there's still many teratogens that are on the market. If you only think of valproate acid, this is a treatment to treat epilepsy, it's still on the market. Why? Because it's a good medication. People take it, it really works. But once they become pregnant, they shouldn't take it anymore because it's really, really bad. Isotretinoin, where is it? I can't see it. Here, isotretinoin. Isotretinoin is a medication for acne, okay? Again, super good medication. It's as teratogenic as thalidomide. It's still on the market, though. Thalidomide is not. Why? Because isotretinoin is also used in men. 50% of users are men. It's a really good medication for acne. So now they put in place risk management programs to actually make sure that women of reproductive age do not get pregnant while on isotretinoin. So there's multiple reasons why medications that are teratogenic are still on the market. So real-world data, because observational research is really aiming at real-world data. So real-world data, and Brazil is a model for combining all data coming from different sources. But basically, we have data from hospital, social media nowadays, unbelievable. We can do a lot of stuff with social media. Mortality, so death registries, you have lab, biomarker, pharmaceutical, medication, pharmacy, so medication that is dispensed in hospital, but also at the pharmacy, community pharmacy, or even over the counter. Claims database, this is very often used. Electronic health record, I don't know if you have it here. In Canada, we're so behind in electronic health record. The US are much more advanced than us for that. Disease registry, you probably have registries of cancer and so forth, or pediatric rare disease or things like that. And then consumer sales. You have IQVA here, I'm pretty sure, and you know they have big database on selling, on the sales of medication. So all of this can actually be used for epidemiologic research. However, these data are not collected for research purpose. So the fact that you have, first of all, it's very difficult to have access many times to these data, but even if you do, it doesn't mean that it's ready to be used for research. There's a lot of validation that you need to do. So again, just hypothesis, research question, real world data, good design and analytics, it's essential. And then you have real world evidence. And then you feed each other so you can have a real learning health system. And we're all, you know, going forward and really, and the majority of countries are moving forward towards that. So those are really examples of where I had the opportunity to actually do research with real world data. But I will concentrate on CAMCO for now. I'm the principal investigator of CAMCO, so I'm going to do a little bit of advertisement, and I apologize in advance. So basically, CAMCO is it's a Canadian structure, but it includes 78 investigators, 8 provinces. Just for you to know, Canada has 10 provinces, so we're missing 2. We're working on it. 3 countries, Canada, US, and France. We have many universities, and we have a lot of patient partners, people with lived experience. More and more, we want to know what they want, what they need, so that our research questions are more relevant. So basically, it's a research platform. It's a training platform, and now it doesn't matter if you do perfect research, if it doesn't reach the prescriber, if it doesn't reach the patient, you have you have done bad work. So we have put in place a robust knowledge translation team to actually bring the data. Of course, we publish in scientific journals, but you know, your aunt will not read the New England Journal of Medicine, so it's good for you to bring the data to your family, to whoever is going to use it, and it's really essential. So this is CAMCO. It's a big platform, and we do many things, and we're hoping that it's going to help pregnant people and their and the prescribers. So again, we have data on 10 million pregnancies so far. Because some pregnancies actually result in children, we have 8 million children, and we have up to 28 years. This slide is old, up to 30 years of follow-up. In Canada, just like here, we have universal healthcare. So the minute you enter in the healthcare system, you're done. You stay forever, unless you decide to move to Brazil, for example. Then you're no longer covered. So basically, this is it. We have, how much more minute do I have? Did I pass? No? Okay. Thank you, Lucia. Okay, so just to tell you a little bit how healthcare systems work. If you want to work with healthcare data, the most important thing is that you have to know how the data that you're using got into the database. You have to know the way by which this data came into the database so that you can fully understand its validity. So in Canada, we have universal healthcare. I'm assuming like in Brazil, right? So this is all good. But us, the healthcare is managed not by the Canadian government, it's managed by the provinces. So that means that although we have universal healthcare, we have 10 provinces in Canada, we have 10 different healthcare systems. Doesn't make sense? I totally agree with you. Discussion for another day. But because it's managed by the provinces, the data, the crude baseline data, cannot leave the province, okay? So I live in Quebec. My healthcare data cannot be transferred to a researcher in Ontario, the province next to me. It just doesn't work like that. So CAMCO, knowing this limitation, CAMCO, in order to have a Canadian cohort, what did we do? We built, so far, 8 mother-child cohorts, 1 in each province. These cohorts are using the same database, billing, hospital, and birth certificate. We use the same methods to do linkage, to define first and last day of pregnancy, to define gestational diabetes, anything. So we have the same codes, same definitions. So we harmonized the cohorts across provinces. The crude data cannot leave the province, okay? But we have identical, almost, mother-child cohorts in 8 provinces. So this is the way that we leverage all this data. And by doing this, we are training a lot of people because, like I said, this data is really difficult to analyze and to code. So we're training a lot of people in computer science and in epidemiology and statistics and programming and so forth. And we're sharing all of our codes. What can get out of the province is the aggregate data. So an average, a risk ratio, that can get out of the province. And with these aggregate data, we are putting in place a surveillance system. Okay, so we have 30 years of data. So for example, we can look at the mean, the prevalence of birth defects since 1995, every year, in each province and across province. So we see trends, and we are proactive in our research strategy instead of being reactive, having a signal and like panicking and doing something about it. So we try to predict what is the problem coming ahead. And obviously, we have a website like everyone else. So it's just for you to know that this infrastructure is really good for the use of AI, like machine learning, let's put it this way. AI is too broad, doesn't mean much. But machine learning, and right now we are building a robust machine learning system so that we can leverage all this data in a more comprehensive way, okay? And this is something we could do also for collaboration for Brazil, with Brazil, for example, because machine learning, I think, is a tool to leverage multiple databases without them specifically touching each other. Okay, so I said that already. Each provincial cohorts are done via a linkage of at least 3 databases, claims, hospital, birth certificate. Everything is done anonymized, really secure servers, so the data is hosted securely. And with all this data, it comes to us, and it's a mess. Like everyone using data will know that. It's not usable, it's not readable, it doesn't make any sense. So, but all this data we use to actually identify the first and last day of pregnancy, and if there's a child, then follow that child. Here we have till 2023. It's an old slide, I apologize. But all the data that we have, we use to actually measure covariates, confounders, comorbidities, socioeconomic status. So the data, although comes to us, can't use it, but we make sense of it with valid definitions and coding. Once everything is done and harmonized across provinces, we're good to go. We're ready to answer almost all questions. This in the making took us 5 years. And we started with really expert people in this type of data. It's just to show you that, you know, when you want to do a study with this data, it could take a long time before you actually make sense of it if you want to do something that is valid. If you want to do something, because out there, you all agree that there's some papers that are not really making any sense. But if you want to go and do something valid, it takes time. And if you want to know more about the methods of CAMCO, this is published. The method remains the same. At the time, we only had data on 4 provinces, but now, just for you to know, we have 8 provinces, but the methods is the same. So what can we do with such infrastructures? So we've done many studies, but just for you to have an idea, we just published a study on children, because we have a lot of children, so we can certainly study children. And I don't know about Brazil, but in Canada, over-the-counter medications for coughing for children, some of them contain opioids in small amounts, but they still contain opioids. And there were guidelines in Canada saying, children below 12 years of age should not use this medication. But because it's available OTC, it's difficult to measure, right? So we did Health Canada, so we work a lot with regulatory agencies. So Health Canada came to us and say, can you look at this because we're worried? So with the CAMCO data, we actually did a study on, you know, the use and who uses it and when do they use, what age, okay? So this is just published. When COVID hit, the EMA were extremely concerned about pregnant women. Well, I don't know if you know, but pregnant women with COVID had more severe COVID, okay? The severity of the sickness of the disease was higher in pregnant women. So EMA, the European Medicines Agency, were concerned because there were no approved medications. At the time, there were no vaccine. If you go back, I know we forget easily. Oh, how timely, talking about COVID, and we hear this. So